people just think the eggs will last forever. Mid to late 40s who are just now seeking help and saying, oh, I want to have a child. And I'm like, oh dear, I wish I had known you 10 years ago. So
what age would you recommend that people come in and see you if they are thinking about delaying their fertility? Hello, everyone. This is Dr. Anita Luanga with my friend, Dr. Oluyemisi Famuyiwa. She is an OBGYN that specializes in reproductive endocrinology and infertility. I'm so excited to have her here on the show to share what she does with you and to share some tips. Dr. Oluyemisi, please introduce yourself to our guests and tell them a little bit more about your journey to specializing in REI or reproductive endocrinology and infertility.
Yes. All right. So my name is Dr. Yemi Famuyiwa. I'm the founder and CEO of Montgomery Fertility Center, and I am also a professor of obstetrics and gynecology at George Washington University Hospital. So I started my residency medical school at Emory, and then I did my residency at Georgetown University Hospital. And then I did my fellowship at the National Institutes of Health. And following that, I went into my own practice and founded Montgomery Fertility Center. So I also serve as a mentor and trainer for residents from GW Hospital, a GW OBGYN program, and recently signed a new contract to help train physician assistants from University of Maryland.
Wow, that is so exciting. You have had such an incredible career already. Like, you're not only specializing in REI, but you're working with residents and also teaching the next generation of PAs. That's very exciting. In terms of your specialty, reproductive endocrinology and infertility, how is that a little bit different from what a regular OBGYN does?
Reproductive endocrinology and infertility is a subspecialty of obstetrics and gynecology. So first, you're an obstetrician gynecologist, but it's someone who goes into further training. In my case, I actually did a total of 5 years after my 4 years of residency, doing research and also the fellowship. And you're going into a deeper dive into the mechanisms, the physiology, the wherewithal of how fertility and the reproductive system works. And so that's the real difference. It's just a really deep nosedive into the fertility aspect.
What are some of the misconceptions people have about fertility or infertility and conception?
So the most common one is, number one, it's a woman's problem, right? And it's really 50-50 if you look at it. And then the number two biggest one that's a headache for me is people just think the eggs will last forever. And I cannot tell you how many patients I see in their late 40s, mid to late 40s, who are just now seeking help and saying, oh, I want to have a child. And I'm like, oh dear, I wish I had known you 10 years ago. So there's that misconception of, or that misunderstanding of time, and the misconception of it doesn't involve a male partner as well.
Wow, that is so interesting. So what age would you recommend that people come in and see you if they are thinking about delaying their fertility journey?
Yeah, that's a good question. So it's not so much the age. If anyone's been trying for 6 months to a year, I think you should seek help for sure. Don't wait too long. Really, if you're over 35, you've been trying for 6 months, don't wait too long. For people who may be younger but have other health issues, maybe you don't even want to wait that long. People who have irregular cycles like polycystic ovary syndrome or extensive fibroids or severe endometriosis, maybe you don't want to wait as long. I always say, if you visualize children in the future down the road, if you look at your crystal ball, children and family in it, and you would like it to be from your own genetic material, then start seeking help.
That is so interesting. And you touched on something, individuals with, say, chronic medical conditions. Would you recommend, say, for somebody who was diagnosed with type 1 diabetes or another chronic condition such as kidney disease, like chronic kidney disease and dialysis, or a child, should those individuals be talking to somebody like you?
Yes, those are unique cases. And definitely you need to start maybe a little bit earlier. When I get patients who have severe diseases or chronic illnesses like that, I like to take a collaborative approach. So I usually work with a maternal fetal medicine specialist. If they have kidney problems, I want to work with a nephrologist. If they have lupus, for instance, or any blood disorders, I want to work with a specialist so that I approach it as more a collaborative approach to make sure that they're helped in the safest manner possible, right? So that for me is a collaborative approach.
That is wonderful. And just for our audience who are not familiar with the different subspecialists, what is maternal fetal med specialist?
So maternal fetal medicine, like reproductive endocrinology and infertility that I'm in, is another subspecialty of obstetrics and gynecology. And they focus on making sure they see the most complicated pregnancies and how do you get that person to successfully deliver the healthiest baby they possibly can. And that is glossing over a lot of stuff, but it's really very complicated, especially when either baby or mother have chronic illnesses or genetic issues. You really want someone who's 24/7 looking at that pregnancy or even how to get to that pregnancy in the safest of manners.
Interesting. So say you have a patient that comes to you and they don't say perhaps have any chronic medical conditions, but they're not very excited about using medications or having surgery procedures, but they still want their chances of having a child. What are some of the things you'd encourage them to start doing?
Absolutely. So just because I'm in fertility doesn't mean that you go straight to the big guns. There's a whole lot of things that you can do. And when people come to see me, I start out with really the raw basics. One of my sayings that I like to tell patients is healthy body, healthy eggs. So let's focus on the health. How can we get your body all tuned up for a healthy pregnancy, healthy eggs, and in men's case, healthy sperm? So I look at things that people ingest, their food. I look at things that people put on their body. We're all aware that there are chemicals out there that can be what is called endocrine disruptors. They interfere with the way your brain controls your ovary and sperm. How do you avoid that in your environment? Because really there's a lot of it in the environment. And how do you avoid toxic chemicals like pesticides in your food? So I start to talk to them about the basics of that. Let's start out with how do we make you the healthiest person you can be? And then we look at, okay, now let's do a preliminary testing. I always say, let's check the plumbing. Are your tubes open? Is your uterus okay? And for men, do you have any issues with sperm? So there's a lot of investigation you want to do before you even get to any treatment. And if everything checks out, then you'd be classified as unexplained infertility. So there are basic things you can start with that before you even get to any assisted reproductive technology. There's things like timed intercourse or even intrauterine insemination if you want to be more technical. But basically, starting with the basics of understanding your body, getting it to the healthiest is where you start. And then if you don't want to do any treatment, once you can even try to understand your body a little better. When is the best time to even get pregnant? You need to know your fertile window, so to speak. So when I give people that education, you might find that people will go, oh my gosh, after I spoke to you 2-3 months later, they come back and they're pregnant and I haven't even done anything. I call it my easiest success rate.
Yes, those easy wins as a physician are definitely very gratifying for a physician and the patients as well. You touched on endocrine disruptors. That is a trending topic line, but for individuals who heard of this, what is an endocrine disruptor?
We can find them in the chemicals that we put in our mouth. We can find them in the chemicals we put on our skin, in the makeup. And these are chemicals that can sip into your body and can interfere with the steps necessary for proper hormone production. Where do you get them? The most common one that people know about is like phthalates, for instance, because they're in those nice smelling aromatic candles. You're actually smelling phthalate. There are some perfume or makeup that have them. So if you want to avoid them, there's an app or a website called Skin Deep, or there are other ones too where you can scan your product and see if it has any of these bad chemicals before you even buy it. And then, for instance, look at deodorant. For years, all the deodorants you find out there had aluminum in it. And then when patients started getting educated, aluminum is toxic. So people stopped buying it. The industry changed and they started making aluminum-free products. Plastic. You all know most Africans like to cook, store in plastic. When you do, you're melting the plastic and ingesting the microplastic. They form tiny particles called microplastics, and you ingest that. And in enough amount, you can find microplastics in human placenta. You can find it in fetal tissue. You can find it in human testes, in the sperm. There was a study that I read that looked at microplastic in the brain. And there was an autopsy series where they found microplastics lining the carotid arteries and making it almost stiffening like a lead pipe, right? So they're everywhere. And by being more careful with what we put in, you really almost have to be very proactive and try to avoid toxic substances.
Wow, thank you for sharing that. That really is food for thought, especially with the way we handle our food, the way we warm our food. in our society and culture, we're always in
Yeah.
a rush. And I think we have to definitely be more conscious about what we're doing with our food and putting in
Right.
our body. And speaking of, I'm thinking of a lot of my patients. People want to do things in a non-medicinal, non-interventional way.
Mhm.
One question I can imagine some of my patients asking: are there any supplements you'd recommend if they wanted to being fertile and having a
So the most common supplement that's missing in a lot of people is actually vitamin D. And I'm sure in Canada where you are with lack of sunshine, it's even worse. And another misconception is a lot of people of color think I'm already dark enough. I don't need extra vitamin D. But if you test them, you find that they're very vitamin D deficient. So probably one of the super vitamins you want to have is vitamin D. If you have a very good diet, actually, that you have a lot of vegetables that use the rainbow color, different sprinkles of vegetables, berries and nuts, you probably have a lot of vitamins in those as well as different fruits. I usually give my patients a little handout of the sorts of foods that are very high in antioxidants. And I tell them, you don't have to eat everything on the list, but it just tells you, it gives you guidance of what's healthy. And then if you are deficient in specific ones, then we can look to boosting it. For my older patients, I like to supplement the antioxidant factor in patients with CoQ10. And I use a brand called NeoQ10 in the Theralogics, because you also have to look at CoQ10 is not readily absorbable. So you want it in a form that can be absorbed. You could take a lot of over-the-counter ones and ingest a whole gallon of it, and it's not doing diddly squat because it's not in a format that can be absorbable. So I think those are the biggest ones. And then for my men, if they have low motility or poor morphology or issues with the sperm, I tell them to throw in there extra vitamin E, at least 400 milligrams, and I throw in there extra vitamin B6, at least 1.4 milligram, and extra vitamin B12, at least 2.4 milligrams. So those are all good antioxidants.
Wow, that is fascinating. And
Yeah.
even for me as a physician, this is not an area of medicine that I'm exposed to very much. So I'm really enjoying our conversation and I'm learning so much. So say a patient has been working with you, or a patient and her partner or her husband have been working with you. They have detoxed their life. They are eating well. They're taking all the supplements and they're still having difficulty having a child. Now they're ready for more invasive or ways to help them have a baby. What would be some of the next things you'd recommend?
You can easily start at the basics with intrauterine insemination, is when we try to stimulate the ovaries to produce 2 to 4 eggs at a time, but no more than 4. You don't want multiples. And then you take the man's sperm and wash it and concentrate it into a small volume and inseminate that into the uterus. That's called intrauterine insemination or artificial insemination. If that doesn't work, then the issue may be at the level of the sperm and egg. Maybe the sperm is not properly fertilizing the eggs, right? You can't tell that from insemination. So you might need to step up and find that out. Is it do IVF, where you take the egg out of the body, you fertilize it directly one-on-one with sperm, and it gives you the advantage of seeing A, did it fertilize? B, did it continue to grow after it fertilized? And the step up is for patients who've had repeated failures or repeated miscarriages. Nowadays, you can actually test if that embryo is even genetically normal, right? Because if you're getting pregnant with an embryo that, say, has trisomy 7, you will get pregnant. However, it's not compatible with life. And those pregnancies they get miscarried around 7 weeks of gestation or 8 weeks. Trisomy 13 is not compatible with life, but it gets miscarried a little later, like 12 to 13 weeks gestation. So you can find out if that's the issue. Now, for extreme cases, I have had patients where their body, you can do immune testing. And I talk about this in my podcast. And I have a podcast, Fertile Talks, where we can test and see if they have an immune reaction to their embryo. And they're simply just seeing the embryo as foreign and it can't implant. So those are really extreme, very uncommon cases.
Very interesting. So say a patient ends up in a situation where all the embryos are viable, they're all healthy. Say you harvested 4, all of them have the potential to become a child.
Correct.
What would you do? Would you tell them to implant all of them? All of them are
Oh, absolutely not.
What are the
Yeah.
next?
No. So I usually recommend one embryo at a time. If you do more than that, there has to be reasons. There has to be extraneous reasons why you do that. Because I tell my patients, like I'm from Nigeria, the natural twinning rate is the highest from where I come from, right? And everybody wants twins. But what they need to understand is 7% of twins have autism, right? So you have to balance it. Number 2, when you have a multiple gestation pregnancy, you risk having a miscarriage of all of them. Your pregnancy is a little harder complications of pregnancies abound. So it may sound romantic and fun because everybody always asks about that, but then there are consequences if things don't go well.
That is very good to know. So, say the individual chooses one embryo or tells you randomly choose one. What happens to these other embryos? Are they? Yeah, I think that's probably the next question.
So one of the things, I have a lot of patients who we've done one IVF, and over the span of 6 years, they've had 3 children, right? They're all, you might call them all siblings from the same pod, but you don't have to have them all at once. They had one, they came back 2 years later, we had another, they came back another 2 years, we had a third one, and so on and so forth. So you can keep them. Then the other thing that you can do with extra embryos, you can offer them for adoption by couples who don't have any access to their own. So you can also offer them for adoption. And that I have so many patients that choose that route as well.
Wow, I had no idea. That's so fascinating. And I even have so many questions, but these are probably more technical, but like in terms of, say, freezing time. Because I think the way we learn scientifically, it's, oh, the embryo is fertilized, or I think the egg is fertilized, and then we keep multiplying and growing. So that's probably maybe too technical for our audience in terms of how you so-called freeze time. But another question I have, so I've heard people talk about when they undergo IVF, they take the child's genetic information or blueprint, and they keep that information for future research studies or for future treatments for the child. Tell me a little bit more about that. That's something I've just heard people say.
Well, so you're probably talking about there are banks out there that store umbilical cord blood at the time of birth, but they're also, I think this is more experimental, still not widely available, is to store embryonic stem cells, all right, to see if that might help in the future. But the most widely used one is to store the blood from umbilicus at the time of delivery and to keep that in storage. So that's available now. People can keep them indefinitely in case they get diagnosed with a leukemia or lymphoma or something down the road. They have their raw stem cells from when they were born that can be used to regenerate. So I think that's an exciting option. Yeah.
Wow, that is fascinating. I think the things we're doing in medicine are mind-blowing. So
Yes, absolutely. Absolutely.
Yeah. So say you have a different couple who's in a different situation. Say they've done multiple embryo transfers, multiple cycles of IVF. There have not been successful at an embryo. And say maybe they've reached a point where it's not financially viable to do this anymore. Are there any other steps you'd suggest that they take?
We are very fortunate in Maryland. We have a mandated state. So a lot of fertility treatment is covered. But for some people in states where it's not covered, it can be a challenge. Do you have to make a choice? How much do you want to invest in this? And like I said, has every aspect of it been looked at? Is it an immune factor? Is it the fact that they have genetic abnormalities in the embryo? And the one that's least known is there a uterine factor? I have a lot of patients who have had maybe a dilation and curettage in the past, or they've had fibroid surgery where the endometrial basalis, the blinding of the endometrium was, so whenever you try to prepare the uterus to transfer, you can never develop a lining. And unfortunately, those patients, if you never can develop a lining, may have to use a surrogate, right? So either a gestational surrogate, if they're able to get their own egg. Other options will be to use egg donors. Now, some people may get egg donors from a family member, or they can turn to anonymous donors. Nowadays, I always caution patients that nothing is truly anonymous anymore, because if we have an egg bank and we have a lot of patients from different parts of the world, that one very specific. I want someone from northern India, not southern India. I want someone from Eritrea, not Ethiopia. I want someone from this part of Kenya, not that part of Uganda. Very specific. So it's hard to match them. So we try to do that. We have a diverse egg bank, but I think they can turn to donor eggs, but understand that maybe 18, 20 years from now, people can go into 23andMe and pop it in themselves and come say, I think we're genetically related. So patients need to be aware, and the donors need to be aware that there's no such thing as complete anonymity anymore. You have to be aware of that.
That is a great point. And definitely in the world we live in, it can cause a lot of complications. And I think all
Yes,
of us have watched all those YouTube videos where people are like, my best friend was actually my sister. And
exactly,
it's
exactly. Yeah,
sometimes even pre-IVF. So I think,
yeah.
yeah, people definitely need to be aware. And speaking of donors, how do people donate, say, sperm or eggs? Do they say perhaps just do it out of their willingness, or are people paid for this? Is this even a politically correct question?
So yeah, we don't have sperm donors in our clinic, but we do have egg donors. So donors can go through our bank, and they can really just look through and try to figure out who they want to use. I think somewhere for patients, I think that I think that for patients who need donors, I think one of the things we do is, and not so much anonymous donors, just counseling patients to let them know that nothing is 100% anonymous, if you will, right? Patients can find out whatever they need. So patients have to be aware and be aware of what they're exposing themselves to. Yeah.
Okay, that's a great answer. That is a great answer. And this is a question I should have probably asked you earlier on in our interview. You alluded to it, though, that people should perhaps come and see you, maybe depending on their primary health conditions. If they have chronic health conditions, a little bit younger, maybe in their 30s. But is there a certain age that you'd recommend men come and see you? Say if they're
That good question, right? I think men should understand that their sperm is also getting older. If a man is getting up to 50, 40 plus, they probably want to consider even freezing their sperm. So we're now telling patients, freeze your sperm. The sperm gets older just as the egg gets older, right? You have increased fragmentation of the DNA in sperm with age, right? But I always tell patients, do not despair. It doesn't matter. You can still collect your sperm at any age, but be aware that sperm can age as well as eggs age.
very interesting. Very interesting. Is there a certain age beyond which you suggest or not recommend that a woman tries to
Oh
conceive?
yeah. So I don't think freezing your eggs at 42 and above is something viable, or because if you look at the studies, the survival rate and the pregnancy rate at that age is very low. Even for women in their 30s, the per egg live birth rate is only 3.1%, right? Ongoing pregnancy rate is like 28 to 30%. So that's why they always recommend that women freeze 15 to 20 eggs to get a 70% chance of having one viable child. And for sure, if people want more than one child, then you might want to freeze a whole lot more eggs than just a few.
So, say if a woman is coming to you, say in her 50s, she already froze her eggs in her 30s, would you still recommend for her to pursue pregnancy? Or are there certain variables that should be considered?
So, someone who's 50 who froze their eggs in their 30s, sure, you can still use your eggs. Those are viable. What we start to look at is when a woman starts to get above 50 and above, what you worry about is the health of the woman. So, we don't really advise that someone try to carry a pregnancy at 51, 52, because then you look at their own health, right? So, the chances of something going bad starts to go up. And I know in Maryland for here, a lot of the maternal fetal medicines certainly do not want to take care of patients who are like 50 and over. So I don't think you'll get a maternal fetal medicine who wants to do that. You can try and get pregnant before age 50, but once you start getting above 50, it's probably not a good idea.
Okay, very interesting. I think a lot of us are seeing in the news random stories of people having children when they're 60s or some extreme ages. I think the oldest one I saw was maybe 70 some. And I'm like, is this maybe it is real? But I've also heard people talking about the potential ethics because there's a lot of politics and ethics. And I think perhaps there's different cultural ways of
Oh,
looking at
I think so. I think that was in the news a while back, several years ago, of this lady in India who was age 70 and did IVF and got pregnant. But I don't think that's a good idea because the risk of pregnancy goes up steeply high. There are complications that could happen. So usually for someone trying to conceive, at least here with our patients in Maryland, you advise no more than age 50.
Very good, very good. So for couples that are struggling with infertility, what kind of support is available for them to cope with this challenge emotionally?
Yeah, so a lot of patients can have fertility coaches to help walk them through the way. A lot of times we have specific counselors that they can work with to help them with whatever emotional aspects they may be dealing with. So I think that helps. So I think working with a counselor, sometimes they also working someone with a nutritionist to make sure that they're getting the right diet to help them with their fertility. So I think it's a combination of, if for people who really need it, they need counseling, they need a fertility coach, that would be very helpful.
For our audience, what is a fertility coach?
A fertility coach is a coach that specializes in helping patients through the fertility treatment phase. Because for some patients, it can be demoralizing, it can be nerve-wracking. So having someone to help them with that anxiety part may be very helpful.
Very good, very good. So what are some of the advances that are coming up in REI that you're excited about?
I think there's one of the biggest thing is artificial intelligence is now assisting in the treatment cycles for reproductive endocrinology. So I think we're just beginning to touch the surface of that. We're going to see more and more of that. So that's going to be exciting.
Yes, I think everyone is into AI these days, even just something as simple as trying to help you correct your grammar. Yeah, it's fabulous. Yeah. I think it's going to be life-changing. I'm going to ask you one more question, more of a personal question. Is there any interesting book that you're reading right now or any interesting TV show that you're watching right now?
I just finished reading, it's called Super Mentors, and it's talk about mentorship. So I really like it because I do a lot of mentoring from both the GW residents, both pre-med students, I have PA students. So it's very fun for me.
Nice. Thank you so much for taking the time to talk with me and to talk with our audience and to share all of your knowledge. I really appreciate you and appreciate you taking the time out of your busy schedule. For individuals who want to hear more about you or they want to work with you, how can they get a hold of you?
So they can email us at F as in Frank, AQ, FAQ, MFC at Gmail. They can go to our website. That's MontgomeryFertilityCenter.com. That's probably one of the best ways because there are contact us boxes in there. And if they just want to follow on our podcast, it's Fertile Talks. And you can get that on Spotify, on iTunes, on Amazon. Anywhere you get your podcasts, we're there.
Excellent, excellent. We will make sure that we have all of your emails, like your website, and definitely your podcast linked below for everyone who wants to learn about you and reach out to you and work with you. But thank you again so much for being on the show and for sharing your time with us. We appreciate it.
Thank you so much. My pleasure.